Okay. Um, for everyone who can hear
Okay.
me on the call, let me just press OK. There are just a few quick announcements before we introduce Dr. Chris Wolfgang. I want to make sure everybody's got on their calendar that October 26th is the Kick It 5K. And also, hopefully you all got my email about our first ever Kosten support group sponsorship. If everybody would just send just $25 or more if you'd like. You can Venmo Tommy, you can put it in the mail to him. We're going to try to put together a sponsorship on behalf of our own support group to show our appreciation. And that deadline for sending that in is August 31st, because you know what? It's just 2 months away.
Right.
So we're going to be there before we know it. The other quick announcement I have, hopefully you got my email about a nice lady. Her name is Miss Bryant in Memphis. Her mother recently passed away from pancreatic cancer, and she has, I think, 2 unopened large bottles of 36,000 Creon.
Wow.
Tom also has different doses from his sweet wife, Susie. 12, I think you said 12,000, 24,000, and maybe some 36,000 as well. So just send me an email if you need it, if you'd like to have it, and Tommy and I will figure out how to get it to you.
I have a truck.
You have a truck. There you go. And now, without further ado, because I know we're limited by time this morning, we have to be out of here by about 10 to 12. Dr. Christopher Wolfgang, or as he said, call me Chris, is up there on our screen. And he was just telling me that he's done how many Whipples, do you think, by now?
Probably now getting close to 1,500. Yeah.
1,500 Whipples. That's amazing. So, Chris, take it away. As people, and people will, I'm sure, be on, getting on gradually, but
Absolutely.
That's okay.
Well, thank you. Thank you, Teresa, for the introduction. I'm going to try to share my screen. Is that okay? So I can show my slides. If for some reason I mess this up, I'll be right back on. I'm not the best with okay, so I'm actually have to send somebody a request to allow me to do it. I just sent a request.
Okay, got it.
You got it?
Multiple presenters can share.
Okay, there we go. Let's see. I'm going to want to share this screen. Okay, can you see my calendar there, I guess, right now?
Yes.
Yes.
Okay.
Yes.
And now I'm going to share my slides here in a second. Now, can you see the slide?
Yes.
Okay, great. I managed to do that without logging off. Trying to not unshare my screen, that's another story. Well, listen, I want to thank everyone for the opportunity. I seriously have been looking forward to this all week. First of all, with the Kosten Foundation specifically, we would go back a long way. I guess it was 2016 when I gave the Kosten lecture, but even prior to that, you know, through the generosity and my friendship with Stephen Berman, he put me in touch with this group. We've applied for funding, and we have generously been funded multiple times over the years. I'm going to show some of the work that I'm going to show today was directly funded by the Kosten Foundation. And I can't say enough how important and how meaningful this is. And before I sort of started, you know, into the talk and stuff, you know, how does this money go so far? Well, the sort of the holy grail for funding of research is NIH funding. And of course, we have NIH funding, and it is very useful. But NIH will typically not fund projects that are sort of out of the box. If somebody comes up with a new idea and we think of trying to do something completely different, they'll eventually fund it when we have enough data to demonstrate that there's some feasibility or that there's some merit in what we're doing. And this is really where the Kosten Foundation has helped. When nobody really else believed in what we were doing, we got support from the Kosten Foundation and have generated some preliminary data, and we've been able to leverage those funds into much more funding because now we've been able to generate some more data. And not that we're the only ones who are working in this area, but we were one of the first ones, and I think the field is growing. But I'd like to point out how I think this has the ability to fundamentally change the survival in pancreatic cancer. And we'll talk more at the end. Of course, there's going to be a discussion. So what I was asked to present is a little bit about what's new in improving the survival. And I want to do it in such a way, I want to address the question. The goal of my talk is to simply ask the question, how can we improve the survival in pancreatic cancer? And then present some results and show why I'm optimistic about the future. Now, the other thing I would like to acknowledge is it's an honor to present this. Amar, I was going to be here, but Amar Javed was going to present this, our chief scientist. Unfortunately, he had a death in the family and had to travel to be there. And so I'm not sure if he's going to log on or not, but a lot of this is the work that we do together. And so not solely my work, and I'm presenting it also on his behalf. So a couple of things with pancreatic cancer, and I think many people know that here, as everybody has been touched by pancreatic cancer. I'm delighted to see we have long-term survivors, and definitely that's what keeps me going and drives me, because I know that a cure of pancreatic cancer is achievable, but we need to be able to do it in most people, not just a minority of people. So one of the problems is that surgical resection is the only potentially curative treatment for pancreatic cancer. The only way to be cured is through surgical resection. Now, here's the problem. If you look at the stage of people at diagnosis currently, and these data are current data, half of people are going to have stage 4. And for all intents and purposes, they're highly unlikely to be cured. Stage 4 means that there's metastatic disease. So in other words, we could remove the primary tumor, but the horse is already out of the barn. It has spread beyond the pancreas to many sites, and surgery can't help. And often they'll get chemotherapy, but the intent of that chemotherapy is really for palliation and to buy more time. There is some exceptions to that, but that's mainly the state of where things are. Now, the other half, though, is clinically localized, okay? And that's a good thing, because in that half, in clinically localized, we still have a potential for cure, because the disease is localized to the pancreas. But it gets a little bit more complicated. If you look at that 50%, and you divide it into the different stages within that 50%, only about 1 out of 5 or 20% are the stage 1 or stage 2 with no vessel involvement, in which the tumor can be technically removed. For a good bit of time, only up until recently, stage 3 really had no surgical option because of the extent of the vessel involvement. Although the biology of the tumor is no different, if it could be removed, there's a chance at a cure. But the techniques weren't developed to be able to cure those patients. Stage 3 has more limited vessel involvement, and some of those patients are operated upon, but again, probably over half are not. So even in localized pancreatic cancer, really only about 20% are really have the best option for a cure. Now, we are working, and I know this is a little graphic picture, but one of the things, and this is not really the research, but that gives me hope, is now that those tumors that involve vessels like the SMA, they can now be removed. There are certain centers that are removing those tumors and replacing it. Here's an example of the SMA replaced by another major artery. The other thing is sometimes we can't take these tumors out because the blood vessels are too small to sew. Well, we're very fortunate here at NYU that we have a gentleman by the name of Jamie Levine who does face transplants. And that face transplant requires the reconstruction of very small vessels. And he does other types of very small microvascular surgery. We've been able to offer people operations because we do these small reconnections now under the microscope. That vessel that you're looking at, we would never be able to reconstruct that without a microscope. That vessel is probably smaller than the cord of the mouse on your computer. And so that is one of the hopeful things, is that more and more in that category of localized disease, we're able to offer them more surgery. But here is the problem with localized disease, regardless if you're stage 1, stage 2, or stage 3. We did this study to define the problem, and it's probably known all too well to the folks here, is that even when we take out the primary tumor, it comes back in about 80% of people. So we simply asked the question back in 2017, what is the pattern of recurrence? When it comes back, where does it come back? And we studied 500 patients, and we looked at when it came back, where did it come back? And about 80% of the time, which is essentially almost all patients, it came back distantly, with the liver being the most common site. So in other words, we do all of these operations, and I say, so why do we do this? Well, we have Teresa and several others here who are long-term survivors. I mean, we should be doing this despite the fact that we can't cure most. The way it is now, which is unfortunate, as I say, we water the thorn for the sake of the rose. We put a lot of people, and I'm sure Teresa will tell you, it wasn't an easy treatment. We put people through a lot of rough treatment so that we end up with people like Teresa. What we want to do is make more people like Teresa, that it's the norm that after we do surgery. So, we have one or two options. We can say, well, we just give up here. This is the way it's going to be. We cure some people, or we can solve the problem. And I think one of the not necessarily maybe the nicest individual, I met him personally, but one of the things, he's a big thinker, and he says, and I agree with this, if you define the problem correctly, you almost have the solution. So that study that we did pretty much defines the problem. It was a simple study. But pancreatic cancer, the least of the problem is the primary tumor. It's a systemic disease. So the solution then to the problem is quite simple. If we can solve these two things, most people will be cured of pancreatic cancer. We need a form of early detection, and we don't focus directly on that, but some of the work we do has implications for early detection, and we need improved systemic control, and that's mainly what we're focusing on. So how important is this systemic disease? Well, these are some data, and even though it gets a little bit detailed, I think everyone can understand this. Now, this goes way back to 2003 and the state of affairs. We had an idea at the time that it was important for systemic control, but they did a study in Germany. This is called the Kosten trial, where they took patients who had early stage pancreatic cancer, stage 1, stage 2. And at the time, we didn't even know chemotherapy in those patients was going to be a benefit. So they did a randomized trial where they flipped a coin, and half of the people got surgery alone, and the other half got chemotherapy with something now which is not considered to be the strongest medication for the treatment, the strongest chemotherapy. But unfortunately, as you can see, after these early stage people underwent treatment, you can see that the rate of mortality from pancreatic cancer is pretty high. But one thing to observe is that 6 out of 100 people were cured by the operation alone. They probably didn't. They were the ones who were caught early, and that shows the impact of early detection. Now, they weren't caught early because we were looking for it. It was just by chance they were caught early. But the other thing that we learned from this study is that an additional 8 people were actually cured by gemcitabine. For those 8 people, gemcitabine was a miracle drug. Now, if we knew who those 8 were, then we could give them gemcitabine, and that's all they would need. The problem is that the other 80%, who were not cured, they died of systemic disease, but we have no good treatment for that systemic disease. But this study, although most of the patients ultimately died of pancreatic cancer, it demonstrated to us that good systemic control can cure people. And so you ask, well, why is a surgeon working on chemotherapy and systemic disease? This is why, because this is our single biggest limitation of curing people is systemic disease. Now, things have gotten better. These are more modern data. And now we don't randomize people anymore to just gemcitabine or no chemotherapy, because we know there's a benefit. So in this study, they flipped a coin and they gave people gemcitabine. And you can see that other things have improved, because now 20 out of 100 are living with just gemcitabine. But the ones that got more aggressive chemotherapy, who had gemcitabine plus capecitabine, another 15% or 15 out of 100 were cured with that. Again, demonstrating the surgery hasn't really changed, but the impact of systemic control. Now, this is great, but still 45% of the people. So how can we fix that in 45% of the people? Well, first, I think it's important to know what is systemic disease. I said, okay, it's systemic disease. It's not, in other words, the horse is out of the barn. We take the tumor out, but it comes back. Well, it's not really that it comes back. It's that it never left. And this is sort of the natural history of a tumor. So based on genetics, and I found that this, to me, when this study was published, it blew me away. It was a study published by Chris Acabuzio. And I think now the study goes all the way back to 2013. And a typical pancreatic cancer is around for about 10 years before we ever even know of it or diagnose it. And this is what's happening. The tumor starts, and can you see my my pointer here when I move it around?
Yeah.
Mhm.
Yeah, the tumor starts as a pre-tumor. It's not invasive. There's a genetic change in the cells, usually a KRAS mutation, that causes the cells to become abnormal. Now, that goes on for about 8 to 10 years. And so that tells us, well, at least there's a window for early detection. If somehow we could detect those cells becoming abnormal and remove them, everybody would be cured. The importance of early detection in solving the problem. What happens, and the reason they would be cured is because the tumor is not yet systemic. It hasn't left the barn. It's still in the barn. Now, over time, like a snowball rolling down the hill, these tumors will accumulate more mutations. And at some point, they accumulate a mutation that allows them to escape the primary tumor. Now, that's what defines a cancer. It's an invasive lesion, and it gets into the circulatory system. And these cells are called circulating tumor cells. Up until several years ago, this was just a theory that, well, they must be getting there through circulation. And I'll show you some data because of the Kosten funding where we've actually isolated these cells. But these cells then leave the circulation. They extravasate is the technical term, and they go into different organs. In particular, for pancreatic cancer, it, for whatever reason, either likes to go to the liver, or if it goes to the liver, it grows best in the liver. And these are things that we're trying to solve. So then we can't see this. We know it's there in patients who have clinically localized tumor, but we know they have other disease that escaped it. You just can't see it. That's systemic disease. And then 2 or 3 years later, we say, oh, it came back. No, it didn't come back. It's that this minimal residual disease that grows and forms these metastatic recurrences. And this circle here is what my group has focused on, because if we could eliminate this minimal residual disease, or MRD, everybody would be cured with the operation. And so this now gets into, and some of this work was supported by the Kosten Foundation. If you go back to, you can see we started some of this work, and well, we published in 2016, which means we probably started the work way back. I'm guessing it was about 2010. We were saying, oh, you know, there's no, these circulating tumor cells, they don't exist. Well, the first thing is we identified, yes, they do. We took patients and we came up with a technique to isolate them. And then we demonstrated that all of these cells are not important, that it's a subset of cells. It's these so-called mesenchymal type CTCs. They're important. And this work, again, some of this work was directly supported by the Kosten Foundation. If you look it up in the literature, you'll see, you know, supported by Kosten Foundation. And here's a series of papers that we published where we demonstrated that it's not all circulating tumor cells, but it's these mesenchymal type that are important. And what does this mesenchymal mean? Well, the cells go backwards. So in embryological development, as we develop in utero as an embryo, cells are very immature. They're undifferentiated, and with maturation, they become different tissues. Well, cancer cells go backwards and they become very undifferentiated. In fact, we went on to show that these cancer stem cells, the ones that are important, are actually have many characteristics similar to stem cells. Now, why is that important? Well, we know that stem cells are able, you can take a stem cell and in theory, reproduce a whole organism. So you've heard about where they have created a sheep. Most recently, you've heard that they've brought the dire wolf back from extinction, right? Using genetic techniques and using stem cells. You can create a whole organism. Well, these stem cells are not really owned by your body. These stem cells, in this particular case, are owned by the tumor, and the tumor uses these stem cells to reproduce themselves. Now, the problem is that some chemotherapies that we currently have, they work great against the vast majority of the cancer, but the stem cells are resistant to it. And so we need to study and understand these stem cells. And again, and that's the work that the Kosten Foundation supports. Now, okay, that's great. So if we study these stem cells, what are we going to do to improve survival? And I'll go through this briefly, and then I'll end with that. And this is where I think things are exciting. So the Kosten Foundation helped us get started, and now everybody says, yeah, you know what? I think you're right. You're onto something. And there's other people working in this field now, which to me is not competition. That's good. We want more people working in this field. One of the problems that we faced, and the additional funding that we've now obtained, we've been able to do is, you would think that if you would take these cells from a patient and, they're very aggressive cells, that you would be able to grow them in culture, but we just have not been able to do that up until recently. Amar Javed came up with a technique in which we are culturing them in chicken eggs. Well, why chicken eggs? Well, first of all, chicken eggs, they're embryological development, so they have a lot of the growth factors that stem cells need to grow, number one. Number two, they don't have a human immune system or a mammalian immune system. So when these cells grow in these chicken eggs, the immune system can't knock them out. And lo and behold, now this is in mice, we've taken pancreatic tumors in mice, we've isolated their stem cells, and we've been able to grow them on eggs. Okay, so for the first time, we can culture these cells. Well, why is this important? Well, when we isolate them directly from human blood, we literally just get a couple of cells, and it's hard to study a couple of cells. They're not alive. We can look at certain features, but we really don't know what makes them tick, so to speak. Now we can grow larger populations of these cells. So here's that experiment where we gave a mouse a tumor. We unfortunately have to sacrifice the mouse. We then take the blood from the mouse, and then we grow it in these eggs, and we've had a great success rate. And you can see that growing in this chicken egg is now a tumor from the cancer. It has nothing to do with the chicken. It's mammalian cells. And you can see here, there's literally thousands of cells, and this demonstrates the staining that they're cytokeratin positive, meaning they're epithelial-like, meaning that they recapitulate the tumor. So these stem cells have now grown into a tumor. So the nice thing about being a translational researcher, so my training, my PhD is in basic science, and I think basic science is great, but basic science, the goal is to just further knowledge, and that's very important. But what is nice as being a translational science is that I'm also a physician. I work with patients and I know exactly what their problems are, but I have the basic science training. So we immediately now went to humans, and we took humans who had stage 4 pancreatic cancer, and we took their cells because we knew there would be a lot of cells. We isolated them using our technique, and we put them into day 10 fertilized chicken eggs, and we were able to actually grow these cells in these eggs. So that is where we are right now, and why this hasn't changed anything up until this point, but why I think this is going to be revolutionary is that now, for the first time, those cells that escape the tumor, we can actually grow them, study them, and isolate them. We know that they don't express MHC1, which is important for the immune system to attack them. So they evade our immune system. We know that they just laugh at the chemotherapy. Okay, so we're going to study the metabolic pathways that make them grow. And then if we find something vulnerable about those cells, we could potentially do a targeted therapy toward MRD. But our overall goal is, you've heard of vaccines for pancreatic cancer and they don't work. Part of the reason that they don't work is that a pancreatic cancer, the primary tumor in a pancreatic cancer, has a lot of stromal cells. Those are cells that are genetically normal, but the tumor hijacks them and uses our own cells to protect itself from the immune system. And we just can't turn those off. We can't get a vaccine in to make the, to really impact the growth of the tumors. But this is a very different situation. These are single cells that are not surrounded by those stroma. They have unique antigens. And so ultimately where we would like to go with this, and I think we now have the tools to do it, is to develop a vaccine not against the primary tumor. As I say, as a surgeon, we have a good solution for the primary tumor. It's sitting in a bucket in pathology. That tumor is not going to kill anybody. It's what's left behind. And now we know what's left behind, and we're going to attempt to develop a vaccine against it. And so I think that, early detection is one of those promising things. And a lot of our circulating tumor cell work is of interest to the early detection people because it can be found early. And so this work has implication for that. But I think equally important in those folks who develop pancreatic cancer, when we catch it as a localized disease, those curves that I showed you where 80% unfortunately get a recurrence, we can eliminate most of those recurrences through directly attacking this MRD or those circulating tumor cells. So I just want to close again by thanking the Kosten Foundation. Like I said, it's been really back when nobody believed us and thought that this was important. You guys had faith in us and trusted us, and because of that initial sort of support, financial support, we were able to generate data, receive many more foundations, and now NIH funding. And we actually now have a group of people working on it. Just as importantly, we have other scientists interested in it and other labs working on it. So it was an honor to present this. This is my entire group of surgeon scientists. Amar Javed, again, who would normally be presenting this, is not here, but he is sort of the chief scientist in the lab and runs the entire group. So thank you.
Thank you, Chris. Can we open it up to questions now?
100%.
Okay, I'm going to kick off. One of the things I recall very well from my very first interview with my oncologist and surgical oncologist when I was diagnosed 8 years ago this month was the remark that the surgeon made. It was likely that I had probably had this tumor growing in me for many years.
Yep.
And so when you talked about how these a typical pancreatic cancer is around up to 8 to 10 years before we ever discover the tumor, it broadens that time frame where we might get some early detection.
Mm-hmm.
And I'm not sure I understood if we're going, if any research that you know of is going in that direction.
Yeah, it is. It absolutely is. There's a big focus on that. So I can tell you that, we collaborate with groups working on it. There's a lot of interest in circulating tumor cells. Interestingly, we can find circulating epithelial cells ever before it becomes a tumor, a cancer, an invasive cancer. The problem is that circulating tumor cells are so difficult to work with on a large scale. So the promising thing then, that would be considered liquid biopsy, but the promising thing about liquid biopsy is that you probably have heard of circulating cell-free DNA, the Natera test, the DNA test for testing for
Right.
DNA in the blood. It can be identified in the blood. And so that's a very promising thing. And there are some early detection tests that are out there, but they're imperfect. And I'll give you one example. Bert Vogelstein's group at Hopkins, a group that we still collaborate with, and Bert Vogelstein is one of the thought leaders in the world on all cancer genetics. He developed a test called CancerSeq, and CancerSeq takes blood from people who presumably don't have cancer, and it looks for 8 separate cancers based on DNA mutations and based on proteins. Specifically for pancreatic cancer, the sensitivity is 60%. That means that if you have 100 people who have early pancreatic cancer, we'll be able to pick up 60 of the 100, but not 40. So it's imperfect. The specificity, which he defined as we're going to make the specificity 100%, is about 99%. Now we could get higher sensitivity, but we would lose it at the expense of specificity, and then we'd be doing false diagnosis. So it's not ready for prime time, but there's a lot of promising things. There's some other tests that are based on extracellular vesicles that are secreted into the blood. Anirban Matra, who is at MD Anderson, is working on that and actually will be joining our group up here at NYU. There's people who are looking at methylated DNA. Nita Ahuja, who's at Yale, is looking at a methylated DNA test. There's a lot of tests that have shown promise, but I think we're still probably a decade away from being able to use it as a screening test in people, just because right now, although it shows promise, it's not sensitive enough. And on the other side, we would generate a lot of harm to patients because we would identify people that really didn't have pancreatic cancer and we'd think they'd have pancreatic cancer. Now we'd have to subject them to an operation or to something like that. But there is hope and there's promise for early detection.
Oh. Well, and like you said, the Natera test is just a point in time that grabs, blood from just one location, and then who knows what else is circulating in your body.
Right. Natera test is we're starting to use Natera more and more for people who we know have the cancer because we can follow the treatment response with Natera.
Yeah.
But the Natera is not yet sensitive enough for screening for early detection.
Yeah.
Chris, you mentioned the KROS theory or whatever before. There was an article in the AARP online, I think, this week. My sister-in-law called my attention to it. Can you comment on that?
Yeah. So there's actually recently a lot of excitement, and for good reason, about KRAS. It was never, so it's a mutation that occurs in about 95% or higher of pancreatic cancer. So most people will have a KRAS mutation who have pancreatic cancer. It also occurs in some other tumors to a less extent, so colorectal cancer and other types of cancers. It has never been anything that we could do anything about. So we had no drug that attacked the mutation. In the past 5 years or so, and there's different KRAS mutations. There's a G12C, a G12V, a G12R. There's now inhibitors for all of these, and they're in clinical trials for pancreatic cancer. And they will probably be a useful tool, but they won't be a cure. So what we see is that in people who are treated with a KRAS inhibitor, they get an initial really good response. And then you see the gross tumor and it all melts away. And then it starts to come back with a vengeance because what's left behind is resistant to the KRAS inhibitor. And so that this research that we're doing has even impact on that, because you know what cells they are? They're probably those stem cells that we talked about. So it is going to be a good tool. It's an important systemic therapy, and I think soon it'll be integrated into standard care in pancreatic cancer, but it's not going to be a cure. It's not going to be the solution in of itself, because of what happens is you just get resistance over time.
Hey, Chris, I have a couple of questions.
Yep.
First, thanks for your work, and also thanks for sharing. So my first question is, are you familiar with something that U of M came up with called histotripsy?
Yeah.
It just was FDA approved less than a year ago, I believe, for liver. And the second part of my question relates to that, which is I read about something called an abscopal effect, which we've used sound waves to liquefy the tumor. And in some, I think it's a small percentage, the immune system is able to, I guess, learn how to attack the cancer.
Yeah.
So what's your general take on histotripsy, and does the abscopal effect kind of relate to what you're doing?
Absolutely, 100%. It has a direct relation to what we're doing. So first of all, I'm well aware of it. As you said, developed at University of Michigan, and it's now a company, Histosonic. We actually do histotripsy here. I think we're one of the busiest histotripsy programs. And it's an ablative technique. It is approved, and we use it in the liver. But again, these are for tumors that have already escaped. So in other words, the horse is out of the barn. And it's an important tool. But the issue is a couple of things, and I'll get back to the abscopal effect, is that the huge benefit to histotripsy is not its ability to ablate lesions, because we've been able to do that for years. We have cryoablation, that is freezing it, thermal ablation, that's heating it, so usually microwave, and then this ultrasonic cavitation, which is histotripsy. And the benefit of histotripsy, you don't even have to make an incision, or there's no poke holes. It goes right through the skin. So that's one huge benefit, and one of the reasons that we mainly use it. Now the question is, so again, if the horse is out of the barn and you have one liver lesion, and I don't mean this in a funny way, but this is what the issue is with pancreatic cancer. If I see one liver lesion, I can get rid of it with histotripsy, with cryoablation, thermal ablation, or even surgery. I can remove it. But what I say, that I don't mean it in a funny way, but it's sort of my sort of farm boy way that I look at it. If you have one mouse and you see one mouse, you know you'll have many, many more mice around. And that's the problem. We can take care of that one lesion with histotripsy, but it's sort of like whack-a-mole. We get rid of that and then 10 others pop up. So it's another tool that is very important, and we use it, but it's not necessarily, going to be the holy grail. Now, there are some caveats, and the caveat is exactly what you had mentioned, is this abscopal effect. So the abscopal effect of what he is describing is that when you destroy a tumor, so first of all, the way the immune system works is it recognizes proteins on a bacteria or on a cell that are unique to that cell, and it attaches to it, and it tells the body, this is not part of me, destroy it. Okay, and that's sort of how vaccines work too. They rev up the immune system. So as I mentioned before, is that the cells that tell the body that this is not normal are protected by this pancreatic cancer. So the way, in theory, this abscopal effect works is that we basically blast the tumor, and the only thing that's left behind are these proteins floating around now, and it allows the immune cells to get in. And in theory, yes, the histotripsy should have this abscopal effect. And there are many groups studying that will, try to determine to what extent and if it's there. So right now it's theoretical. My guess is that they will find something, and that may ultimately be the big benefit of abscopal, of the histotripsy, is the abscopal effect, because there, in theory, you could treat one lesion and it would have impact on distant lesions. The thing is, though, that I say, even if that works, it's not going to be the holy grail, because radiation also has an abscopal effect, and that's known and it's been studied. So if you irradiate one liver lesion, you can get an abscopal effect, and it can be helpful, yet it still does not control all of the disease, probably for the reasons that we talked about, that the immune cells, even if they are revved up, and even if they are introduced to the antigen, they still can't get into the other sites. So all of that will be one more tool. Though, there will never, in my opinion, in any cancer, be a single magic bullet. It's going to be the combination of tools in which the histotripsy is important.
What limitations, since you do a lot of histotripsy, well, your organization, I don't know if you do it personally.
Yeah. Well, my group does it. I don't yet. So Brock Hewitt in our group is I can show you this picture.
I wondered what limitations you put on who you treat. For my doctor, my oncologist told me I am not a candidate because I have 3 or 4 large tumors and about 30 plus total in my liver.
Yeah. So there's many things that we look at. So there's some very practical things that we do that right now, and the technology will get better, we can't get around. So if you have a lesion in your liver is it's in your abdomen, but it's way up underneath your rib cage, and the lungs actually surround the liver. So the thing with histotripsy, it works on ultrasound waves. So what it does is it takes two low energy ultrasound waves and focuses them at a single point. And then in terms of physics, you get what's called constructive interference, where the waves get stronger and they ablate it. So you have to get these ultrasound waves in. Well, ultrasound waves travel really good through solid tissue, through liquid, but they don't travel through air. So tumors that are high up in the liver, the ultrasounds won't hit them. So they're good for the lower segments of the liver. The other thing about the histotripsy is that once you reach a certain size, it's hard to ablate the entire tumor because it just becomes too big for histotripsy to do. And, that could be part of the case in you. But the other thing specifically for what you had mentioned is that there's multiple ones. It just is not feasible to go after multiple ones. Now, again, and I'm just talking in general, if a person is not a candidate for histotripsy, that doesn't mean, oh, well, now there's nothing. There's been a lot of things that are tried and true, in particular for neuroendocrine tumor, which is, you had mentioned, this is the type that you have, is that they do things that are called liver-directed therapies. So TACE, you probably have heard of TACE, where they give chemotherapy right through the artery, almost like a heart catheterization, but they catheterize the liver artery, and they send chemotherapy, or they cut off the blood supply directly to those lesions. In Europe, in addition to doing that, they add a radioactive compound that goes to it. So it's sort of like radio-directed therapy to the liver. There are the traditional forms of ablation, and actually the ultimate thing is, if there's no disease beyond the liver, some patients with neuroendocrine tumors are a candidate for a liver transplant. So removing the entire liver and putting in a donor liver. And we have a protocol for that here. The thing is, it's not that we want to be selective about it. There's only, when you look at the people who will benefit from a liver transplant, it's a small group. And so it's not, most of them, ultimately it's not going to help them, and we have to count on those other things. But those are the other options. It's not only histotripsy if it's not in of itself an option. So you should not be discouraged by that.
Great. Thanks for your info.
Hi, Stephen.
Steve, you muted.
Everybody was wondering where you were at the beginning. I said, I bet he's in the hospital taking care of somebody, and it looks like that's where you are.
Even better, I was operating. So
There you go.
starting at the beginning. Great to see you, though, Chris.
Good to see you, Steve.
If you have a question, please feel free to unmute and ask away.
Hi, Chris, this is Jeffrey Goldberg in Memphis. With regard to NIH funding, I heard you mention it. Are y'all have y'all had cuts due to, I keep reading headlines about NIH cuts. So have you guys been able to avoid it, or how's that going?
No, I think it has hit everybody. So there's one of the researchers in my group who almost a year ago got scored on an NIH grant, almost a perfect score. So clearly was going to get funded. And it's only been a week or so ago that we found out that the money will be released. So the changes that were made to the NIH infrastructure, not that they are intending to be obstructed, but it has just slowed down the process, number one. Number two is that I think there's going to be certain fields within science that are going to be de-emphasized, that it's just the funding will not be available, or it's just going to be much, much more competitive to get those fundings. And a lot of those things are, I believe, in what's the so-called soft sciences, things that are not necessarily benchtop research. I don't think that cancer type research is going to suffer from that. But the bigger thing, and it's actually not the direct funding to the research that has impacted thing, is that in order the research funding that you see these, when you read in the news these multiple millions of dollars that universities are getting, it seems like a lot, but when you look at the individual funding to labs, the money is not an extensive amount of money, and the equipment needed to do the research is expensive. So it has to have a little bit of a factory thing. You know, if you're running a factory, you need a factory building. You have to keep the lights on. You need the equipment on the assembly line. And that traditionally has been funded by what's called overhead. So if we get a grant for, say, $1 million, you know, additional money comes overhead to the university so that I have a lab to work in. So that when I go to the lab, it actually has electricity and lights. And so that it has the equipment to circulate so that I can isolate the circulating tumor cells. That is getting hit across the board. And it hasn't brought people to their knees, but it will be tough over the next couple of years, you know, to for universities to keep the infrastructure. You know, and is it reason for alarm? I don't think it's reason for alarm. The pendulum swings back and forth. I think that scientists and clinicians are dedicated to what they do, and they'll always find a way. Maybe the main types of funding will shift from NIH types of funding to this. So I think now in a climate like this, that foundational funding becomes even more important. And at some point, foundational funding may surpass NIH funding in getting the research done. We don't know which way it's going to head, but I can tell you, scientists and clinicians in general are resourceful people. They're not going to give up, and we find a way. But so it's been an impact, but it hasn't brought us to our knees.
Andrew, we haven't had a chance for you to introduce yourself yet, and I think you might want to help answer that question as well. You want to unmute? Say hello.
Hopefully my internet connection will hold up. Yeah, I can echo what Dr. Wolfgang was just saying regarding NIH. There has certainly been a high level of stress, worry permeating across the institution. I've been talking with so many of our researchers. My work is focused in cancer research foundations. I think what Dr. Wolfgang said about resilience is really important because our researchers are such incredible people. They're so dedicated. They're so passionate about patients and really, moving the needle. And I think the thing that I'm kind of witnessing at this point in time is, like, as we were having this discussion today, I really feel like from what I'm learning and some of the other grants that I'm working on, is that we are really on the brink of extraordinary breakthroughs where we can diagnose, detect cancers at the very earliest stages. That's really the goal. It's a goal here. It's the goal with other difficult cancers, lung cancer, brain cancer. It's a difficult and interesting time all at once. And so I feel like the work that I'm doing, which is collaborative work with groups like yours, to sort of to see you all here in person today. That's such a privilege for me to see you. So I do feel like we are kind of at the sort of the outset of a new era. And I feel like we have people at NYU Langone who are leading the way. And so it's a privilege for me to work with them, to work with you. And so I applaud all of your efforts. And, my family, my friends have been touched by cancer, pancreatic cancer. So to do what I do on a day-to-day basis to support Dr. Wolfgang and his team, Dr. Javed, I've worked with them for about almost 4 years now. It's great work. So just want to echo what Chris said and say thank you, because what you're doing is important. It makes a real difference. And so if we can continue our partnership, that would be an extraordinary thing. So I'll just say thank you. If anybody has other questions for me, happy to field them.
Thanks, Andrew.
If you have a question for Dr. Wolfgang or for Andrew at NYU Langone, please unmute your speaker. Alan, do you have any comments?
I was gonna, Jeffrey asked the question that I was gonna ask about the NIH funding. What we read online and papers has greatly concerned me, and I'm glad to hear what Chris said about it. Although it's not good news that it's not bringing them to their knees. That's good, because in reading everything, I was plenty worried about that. And where are we going from here? And I think Chris has answered that question somewhat, although no one knows what's going to happen in the future as far as funding goes. So I'm glad we're going forward with what we're doing, and we appreciate Chris and Andrew being here. And I think you've done great, Chris, to explain what you guys are doing in your labs. And we feel more confident than ever in what you're doing. And hopefully, as Andrew said, we can continue our partnership for many years to come.
Thank you, Mr. Kosten.
I just have a comment about what you were saying with the NIH and overhead. I work for the University of Tennessee Health Science Center, and it is a very big concern because we are a very large research university. And
Right.
so I work in facilities. And so in the administrative operational side of things, they have proposed a 5% cut in certain areas so they don't have to lay people off, but also it helps to cover that overhead. So I understand what you were talking about.
Of course, I'm biased. I'm at NYU for a reason. I love working here, but I got to tell you, I was impressed by our leadership's response immediately months ago when this was on the horizon. We got emails from the head of research of the research organization, a dean for research, that saying, "Look, this is coming, but we're going to tighten our belts and we're going to figure this out." And we really, and Andrew, maybe you can comment. I haven't seen like that the necessity of, mass layoffs, or we're losing critical mass. I mean, I understand that, I'm sure the university is absorbing some of this cost, and I don't know how long it's sustainable, but even at the higher level of institutions, and I'm sure it's like that at many places, that, they're committed to keeping this research, not only ours, all types of research going. I mean, at the end of the day, that's why university hospitals exist. It's not only caring for patients, but it's improving things overall. And, it's a core part of the mission.
Yeah, I can comment a little further on that based on what I have heard. And I think NYU Langone, we are not immune to any of this. Certainly there's been like a lot of stress, as I alluded to a few minutes ago. But I think we are, relative to other institutions, perhaps set up in a way with our business model, but also our massive clinical side, that we have certain kinds of strengths that may help us weather this. We know that there are other health systems in other states where, like, for example, I think Alabama, where their medical institution, their school, is like one of the top employers in the state. So that's very concerning. That's actually an example of a hospital that we do a lot of collaborative work with. So I've heard of docs that I work with, researchers who have had their grants cut. The buzzwords, DEI have made them targets for things. So they've had to figure out how to strategize and sort of position their work in a way that will, not put them on the radar. So that's definitely going on. And what they're doing is also, valuable work on population health. So we have had some grants that have been cut. I think if we had this meeting 2 weeks ago, I think the tone might be different, because that was before the recent reversal, where I think I was hearing about a 40% cut that was coming. But that appears to have now been taken off the table for the time being. But that uncertainty, the coming and the going, it's very difficult in such a large kind of, business environment for us to plan. And we have talented postdocs who come to us from all over the country and all over the world, and their positions have been supported by the indirect costs. And NIH direct funding does not fund certain types of administrative costs, which are critical to running like a lab like Dr. Wolfgang's lab, and many others.
If I may interject as well, because
Sure.
I bring kind of a unique. My name's Philip Laster, and I'm a patient. Some of the research that y'all are discussing isn't directly applicable to me because I have been, diagnosed as, inoperable is the term used. So, I am curious to understand how the relationship between the research that, is being funded by the Kosten Group and potentially others with the NYU. And one of the things I'd like to say, looking to hear a response to that is, my career has been in procurement and technology procurement specifically, which is managing cost, helping businesses manage cost in downturns in the economy. So my recommendation to everyone that's part of the research is to, if your university or organization doesn't utilize their procurement team to help reduce cost, then you're missing an opportunity. Because some of the things, that businesses hear about bad economies and, costs going up is that we rally around trying to control expense and reduce expense. Therefore, the funds that are provided by NIH or other organizations can go further. And the other thing I would suggest is that I have not seen a lot of, at least in the Memphis area, is the sharing of ideas, the sharing of research, the sharing of equipment. And, I heard the comment that equipment is expensive. I would be looking at those suppliers and trying to reduce the cost of that equipment. And then understanding supply chain wise, where's that equipment coming from? Because there's certain countries, not to get off track, that, take advantage of situations like this. So I'll just throw that out there as an experiential comment, as well as if I could hear kind of the response of the Kosten Group working in areas where chemotherapy is the primary, if not only, option for treatment.
Well, I mean, I hear exactly what you're saying, and I think that's absolutely important. When you have a fixed revenue or revenue's tight, the only thing you can do to fix your margin is to reduce your costs. And I think I don't know what has been done on a global scale. I can tell you personally that even before this came around. So I'm Pennsylvania Dutch. I don't know if you've heard of Pennsylvania Germans. I grew up on a farm. We threw nothing out and still don't throw. So in my lab, we actually, even now that we're more well-funded, there's things that are intended to be disposable that we actually wash and reuse. And so it is important to maximize that funding. And we have, as another example of what you're saying, the device that we have used to isolate these cells, we've negotiated because it's our work is a benefit to them because it demonstrates the power of the equipment. We've actually negotiated getting a machine for free, and we have to buy the consumables. So we do those kind of things. And then maybe Andrew can talk on a global scale, but I know we do have a supply chain team that looks into that. And
well, and I didn't want to derail. I just really,
no, it's important. It's
hear a lot of what I call knee-jerk reaction of the media. And I want to put in perspective that people that run businesses know it's through this. And I have found that a procurement strategy is key to do. I don't want to offset the conversation. Just want to make sure that, that people hear another voice.
Yeah, I don't think it offsets it at all. I think it's spot on, and I think it's good advice. And as I said, that not only at NYU but everywhere, I don't think I've ever met a researcher who hasn't been passionate about our research. And the reason I say I'm optimistic about the big picture and it won't bring us to our knees is that we will find ways. But what you had pointed out will probably be much more important than what it used to be, and that'll be one of the ways that we'll get things done is to really take a closer look at our expenses.
And I know AI is a bit of a controversial subject for some people, but I think that our institution has been deploying AI with the supply chain to make sure that we are optimizing costs and our inventory, because we deal with millions of patients every year. Running a lab is a very expensive proposition. So, another point of pride for NYU is how disciplined we are.
The frontier positive, there is a lot of options that are growing that I've done research on, but I'd really like to hear again how the hospital, Kosten Group, and some of the university people are working with the fact of chemotherapy for those. I know there's a term immunotherapy that's being thrown out as topics of conversation and optimism as well.
Steve, you might want to address the chemotherapy aspect of it.
Well, I think it goes back to what Chris was talking about earlier, is that, I think the one target we really haven't had in pancreatic cancer is, something that we can use immunotherapy on. And that was his whole discussion on the KRAS mutation, which is very common in most patients with pancreatic cancer. And those drugs are in early clinical trials. And, that will probably be the next, in my mind, kind of advance in care of patients with pancreatic cancer. There's many cancers now where, just like Chris said, they'll get an initial dramatic response oftentimes, and sometimes it can be, we can maintain patients in remission, similar to like Keytruda for lung cancer. A lot of times I can just maintain patients in remission, and so I think these new immunotherapies against the KRAS mutation, which again is probably in about 90% of patients with pancreatic cancer, will be our next major advance. I don't know if that answered the question or not.
It generally does. Again, I'm just looking at other options, and my doctor actually this week mentioned the KRAS option, and that it was in clinical trials as well. So, and I am in discussion with some other research organizations about clinical trials as well. But so I was just wondering if the focus really was more towards resectable type of solutions versus the balance between, and I know that y'all have mentioned, I think the slang terms Gen-Zim, whatever, for the some of the chemotherapy. But anyway, I just, from a personal aspect, I've been told operation is not a option. So, my ears kind of peak up, or, when I hear things of that nature. But then, personally, time is of the essence for me. And so really trying to look at other options as well. So anything y'all have there, that's great. If not, I understand as well. Not to get again to derail the conversation.
Well, I think Dr. Wolfgang would agree. I mean, there's many times the chemotherapies that we have for pancreatic cancer, that our frontline regimens are actually quite good. And a lot of times we can, turn pancreatic cancer into a chronic disease like diabetes for a period of time. I mean, I don't think any of us feel like chemotherapy alone is a cure, or if it does, it's very, very uncommon. But it can, keep the disease quiescent, just like immunotherapies can. And so, and there's been a lot of advances in the last decade with regard to pancreatic cancer. And I think Dr. Wolfgang would echo my comments on that. We just need to, we're moving forward very quickly. And I think the work that he's doing, as well as many others across the country and the world, we're going to see a dramatic change in the next 10 years. I really do feel that.
All right. Thank you.
I agree. And this work, by the way, it does have implications for even a non-operative patient. We have to identify a model to study, and right now, just because it is the simplest model, and we have to start simple, is that in localized disease, we are studying systemic, disease that you can't see. In stage 4, if we knew that say somebody had, and I'm just making this case scenario up, one liver lesion and one, then the primary tumor, well, that's metastatic, but we knew that's all they had, we could cure them too, because we could take out those 2 lesions. It gets back to what I was saying, that when you see one, they're sort of like mice. The mice are the MRD. That's what we're studying, is the MRD. So that if in the localized model we work out MRD control, it'll have implications for all stages.
And just for me, you may have already said it, but, and I know I come from the world of technology where acronyms fill in for a long, lengthy word, but what does MRD stand for, please?
Yeah, that's that minimal residual disease, the disease that we leave behind if we take something out. Technically, if we haven't taken a tumor out, we can't call it minimal residual disease because we haven't taken it. It's there. The technical term for that is disseminated tumor cells. Those microscopic disease that we know is there, but we can't see it.
No, I appreciate it. And again, I thought I wrote that down, but that's the only way I remember things now.
No, that's okay. Yeah. It's a lot of jargon.
Exactly.
It's hard to get around some of it.
Been there, done that. Understood.
Tommy, and hello to Jean and Pam there in the library. It's great to see you all. Do you all have anything to add or ask?
How about introducing our 6 patients we have online today?
Good idea. Why don't you start there?
Okay, we have Gene Sparks, had a distal pancreectomy, stage 4, went through chemo, reduced the tumor. And how many years now, Gene?
7 years, 4 months.
7 years, 4 months out.
Great.
Lisa, go ahead.
I'm an 8-year survivor this month. Was diagnosed August 2017 and had the FOLFIRINOX 4 rounds, had a little stereotactic body radiation therapy on the tumor, and then had the Whipple in January 2018, and then more chemo afterwards, which was a killer. So this summer, was probably the last time 7 years ago I stopped my chemo. So I'm so far so good, and get my checkups every 6 months and check my sugar every 3 months in between, just to make sure that I'm keeping my glucose and my A1C in line. So very blessed. We have,
Jenny.
I see Jenny Yates. Unmute and tell us about your brief history.
You're muted, Jenny.
Still muted.
Bob, you want to unmute and go ahead?
Yep.
Oh, here you
got
go,
it.
Jenny.
Thank you. Yes, great to see everyone, first of all. I was diagnosed with pancreatic cancer December 2023, and I was stage 2, which we're very lucky. And I went through the chemo, and then surgery. I had the pancreatectomy surgery, not the Whipple. And then I had chemo after that. And since my surgery, which was June 2024, I have, I've been clear, or whatever you want to call it. So I'm now, my oncologist has moved me into every 4 months getting the, blood work and scans. And so my next one will be in 2 weeks. So
Good.
That's great to hear.
That's great.
Yeah, very.
Okay.
I feel very fortunate,
Yeah.
but as we all know, it's there,
Yeah.
Yeah.
Bob O'Grady also had a distal pancreatectomy, right?
Yes, I did. they were searching for something for almost 4 years before they really determined it was pancreatic cancer. And then, of course, yeah, I had the distal and 6 months of chemo. Yesterday, I received bad news. Apparently, it's gone to my lungs. I appreciate your presentation, Dr. Wolfgang, because apparently that's what's going on. My CA 19-9 went from 18 to over 230 in 4 months. And the one lesion in my lung has increased 3 millimeters. I don't know what that means. And then I've got 2 more in there. So I'm going in for another PET scan and a lung biopsy as soon as they can get it scheduled. So pray for me.
Well, I will. Sorry to hear that. But there's a lot of tools now, better chemotherapy. And I've seen, unfortunately, I've seen cases like this. I will tell you that having lung-only metastases, you don't want to have any recurrence, but lung-only metastases, people can live for long time with lung-only metastases. I see Stephen shaking his head there. He sees it too on a daily basis. I've had people who live to die of old age with lung-only disease. So, it's, I wish you could have no recurrence, but there's reason for hope. And again, the chemotherapy that we use now and the clinical trials with the KRAS inhibitors, there's a lot of options to treat this.
Well, I appreciate that. Yeah, I've got something on my liver too, but they haven't determined what that is yet. But like I said, I appreciate the presentation because it's helped a lot to understand.
Great.
Basically.
Thanks, Bob.
Yep.
We have Jewel, if you want to unmute yourself and give us a short update on how you're doing. Jewel Gatewood. You're muted. You're muted.
There you go.
Can you hear me now?
Yes.
Yes.
Let's see. So 3 years ago, diagnosed with pancreatic cancer, then the Whipple procedure, then chemo, and the last that I've done is the oral chemo with radiation, and that stopped 6 weeks ago. So I'll have a CT on this Tuesday to see if the oral and the intravenous chemo and the radiation has helped any, or if it spread. There's so much information out there that it's so confusing. I remember 3 years ago, I had to look up where the pancreas was. And so it's been a flood of, and I thank you, Dr. Wolfgang, for coming and being with us and telling us everything that you're working on. It's so encouraging. But I was just thinking about, like, with my Tuesday's doctor's appointment, what's the best question to ask him? I'm so inundated with this, and it can spread. They've talked about liver cirrhosis, kidney cirrhosis, metastasizing, and I try to keep.
Yeah.
Go ahead.
It's overwhelming, I'm sure. And the other thing too that we, probably don't focus on enough is even, that people who are cured, it's just the burden of every 3 months it comes around and you have to sit and you have to wait, and just the mental burden of that. I know is tough, and I wish we could sort of just be able to say
the questions to ask.
Yeah, but the questions to ask, I mean, so, in this surveillance, which is what they're going to be doing, the CT scans nowadays and the imaging is pretty accurate looking for recurrence, and they'll look for a localized recurrence or recurrence in liver or lung. But and sometimes the CT scan, can show some things because you've had a Whipple. Now your insides are a little bit different. And so there may be some things that look different. That doesn't mean it's necessarily tumor recurrence. I don't know if you express CA 19-9, the tumor marker, but
yes,
you'll get tumor markers, and they'll be looking for a rise in those. Now, small up and down is nothing to worry about, but They have that to survey, and then the Terra test and things like that. But
And they tell me about that CA19 because mine went from 14
mhm.
after the Whipple surgery. A year later, it was back up to 900. And I think the last CA19 I had was in the thousands. I couldn't even believe that you could
It
be on the graph.
Yeah.
makes me feel better, Gene. Mine was 40,000 when I started. And I'm looking at 3,400 and happy. So, you know, perspective's everything, I guess, but not to take away from your comments or concerns, but just for perspective.
Yeah, I mean, 1,000 seems high, and it is, but yes, we've seen it in the 30, 40,000. The other thing is you've obviously now you've gotten probably capecitabine and radiation. So, you know, the thing that I will tell you is don't get discouraged. Sometimes the CA19-9 bumps a little bit because it's killing the cells that are there. So this next one may not be a good marker, but it gives them something to follow over time. And, you know, radiation is a very effective therapy. So then you'll be looking for that to go down over time.
Hoping, definitely.
Jewel, have you gotten an answer for the fluid issues you were having? I know that was very concerning.
You know, I get 2 months, no chemo, no radiation. I'm feeling better. The chemo's leaving my body. I can feel it. I've got 2 months off of everything. And so my feet start swelling. Then my legs, my calves start swelling, and then my legs. So I didn't know what was going on. I'm treating it with ice and Epsom salts. My mother kind of got in there. So so I was admitted into the emergency room on Tuesday, this past Tuesday. And I had a drain I put in. I'd already had 2 drains from West Clinic, and but it's a bacterial infection, and I looked like I was 9 months pregnant. I had a UTI, which I didn't realize because I didn't have any symptoms of a UTI. So it's just this every damn day, you know.
Yeah.
It's like
I know.
Jewel cannot get a break here.
I know.
But
I'm glad you went to the ER.
well, it's
always glad to see your sweet smiling face, though.
well, you're so sweet. Well, when I couldn't, I was having trouble breathing, so that was the Jewel. You need to do this.
Yeah.
It's a tough course, but hang in there.
Yeah.
As you can see, this disease can be beat. There's
Everyone.
living proof here.
We only have about 10 more minutes. Rick, if you do you have an update for your treatment and how it's going?
Sure. Quick backstory. It's been about 2.5 years almost since I was diagnosed neuroendocrine tumor. I get a lanreotide shot every 4 weeks. That held things static for about a year to a year and a half. Then I did 6 rounds of capecitabine and temozolomide. And after that was stable, I just had an MRI on Monday because I stopped the chemo after 6 rounds. That would have been the end of February. And this MRI, I need to speak to my oncologist on Monday, but the tumor markers are low. My tumors are functional and they produce gastrin. It's high, but it was like 2,500 and it's 400 now, right? So
Wow.
it's manageable with like Prilosec. And the U of M portal sends me the results before my oncologist necessarily evaluates them. And the impression is no change. So I'll probably get another 3 months of no chemo and
Great to hear. Great.
live it up
Great.
is what I'm gonna do. So anyway, that's it for me.
Molly and Philip,
Philip. Hey.
tell us at
So-
what point you are in your treatment, Philip.
Just in quickly, because I know I get verbose, but anyway, I've been really coming in for a year of diagnosis of having pancreatic cancer. In August, some, I guess, 1 year surviving. The latest update from my doctor at West Clinic, Dr. Bettini, was that based on a CT scan, is that the tumor in the pancreatic or in the pancreas has reduced in size. So very good news there. Not something I was expecting, but so it was a pleasant. It has metastasized from past reports into the spleen. Those in the tumors in the spleen have calcified, which is a term that sounded really good to me. The only concern that Dr. Bettini expressed was that I do have continued tumors in the stomach cavity that, is an area of concern, I guess, but based on the CA19 score or number went down to 3,400 and change, which is actually a positive based on past results. So last Tuesday was a positive report overall based on where I've come from and where I'm at, and I appreciate everyone's thoughts, prayers, and the work that the doctors, researchers, and everybody. I lost my mother, I lost my sister, both to pancreatic cancer. Somehow we finally dawned on it may be genetic in my family, so we're kind of running around with that thought. My brother's on here as well, who has become one of my research developers in not by trade, but by hobby, I guess, or desire. So anyway, that's all I have.
Thanks, Philip. I have a quick update from Jackie Walls. Y'all remember Jackie? She was unable to be here this morning. Unfortunately, her last CAT scan showed new small spots on her liver and lungs, and there's another small spot that has appeared that was in addition to the last time. So she's back on chemo, 3 weeks on, 1 week off, and she had a liver biopsy this week, and we'll get the results next week. So y'all keep her in your prayers, and hopefully she'll be able to be with us in September when our next meeting is.
Jerry Ballard did not get on this morning. He was trying, but something would not connect with his computer. So I will share all of this with him, and we'll get him a copy of the recording.
Well, definitely. And Dr. Wolfgang has offered to email us that PowerPoint presentation, and I will share that with the group. Our next meeting is the second Saturday in September, and by my calendar, that is the 13th. So y'all mark your calendars for that. And I wanted to just say hello to other people that are not patients and not survivors on this call, that we always appreciate their participation. We have Zeta, whose husband passed away. How many years ago, Zeta? Unmute and tell us. Unmute.
Six years ago, May 17th, 2019.
Yeah. We have Tom Fagan. His sweet Susie just passed away last month.
We consider her to be in full remission.
Yes, we do. She's kicking up her heels for sure now.
I might add that the Zenpep Creon-like medication given me by Jenny Yates went to Jackie Wall, and she's using it as far as I know. So thank you, Jenny.
Great. And again, just a reminder, we have a lady that talked to Alan and she got in touch with me. She's got 2 or 3 bottles of these 36,000 Creon pills that y'all know how expensive those are. If any of you are taking them and need them, please let Tommy or myself know. I also see Grayson and Margaret, and he's been posting some wonderful pictures of our group over the years. He's sending us hearts right now. He has been a longtime friend, both he and Margaret, of our group, and we really appreciate their support. Grayson is the resident magician at the Memphis VA Hospital, among other talented things, and he keeps us laughing and smiling and gives us a lot of support.
So
And
Teresa,
yes,
Teresa, you say longtime friend. I guess that's a gentle way of saying, yes, we're old.
thank you
And
for
also I should tell you, I told my wife that she should embrace her mistake. So she gave me a hug.
Good
Y'all
on
are
you,
too
Margaret.
Y'all are too cute. And Rosalie, we really thank you for being here and reminding us about the last time the Kosten group was addressed by Dr. Wolfgang. That was great.
Thank you. It was a privilege to be here.
It's good to see everybody.
As always. Alan, Tommy, do y'all have anything to wrap us up here?
No, just it was a great presentation. I'm glad so many of us were online to hear Dr. Wolfgang, and I think we learned a lot, and look forward to doing it again in the future.
Thank you.
Yes.
Yes, Chris, this was amazing. We really appreciate you taking the time and coming to see us. Remember, we are taking some funds to have a sponsorship for our 5K coming up October 29th. So if you're having trouble getting money to me, I can find you. So let me know.
Well,
Yeah, this will be the first ever Kosten support group sponsorship that we'd like to do this year at the 5K. And so
we haven't. Go ahead. We have enough for the friends. So the next level is 500. So we're looking to get.
we're gonna do it. We're gonna do it.
you guys are doing great work. It's it just, as I showed, had the impact that the money that the funds have in trying to move things forward, and you all play a part in that, and hopefully you can see directly what the impact it has, and then hopefully in one of my updates I can show where it's actually something is being used in patients and impacting the survival, and it all comes directly back to this group. And so
Right.
I have one quick question.
Yeah.
For Chris.
Yeah.
Do you know of many or any other pancreatic cancer support groups like you've seen that we have this morning around the country? We can't find very many at all.
I'll tell you. There's another one that I work with a lot, not as long as I've been with the Kosten group, and it's called the Nikki Mitchell Foundation, and lo and behold, they're in Nashville. I help care for a patient, Nikki Mitchell. I mean, obviously it's no HIPAA. She ultimately died of her disease, but she was a music agent to Waylon Jennings and knew Johnny Cash and knew the group, and they're based in Nashville. And they remind me very much of this group, it's relatively small, but highly dedicated group, not only with the funding that they fund some grants like you guys do, but also with the direct patient interaction, patient support. So for example, they have a program where patients who need to travel for care, they'll help pay for a hotel room or pay for some of the travel.
That's great.
And I would be happy to connect you up because, it's obviously you guys all have the same mission, and it's moving the science forward and caring for patients. But of all of the groups I've ever worked with, those two groups, which are both near and dear to my heart, you remind me of each other. So Nikki Mitchell Foundation. Rhonda Miles is the woman who runs it.
It's good to know because we had not heard of anything in Nashville. And
Yeah.
in fact, we've had people, I don't know how many years they've been in existence, but we've had people come over from Nashville to our meetings.
Yeah.
And, they couldn't find any place, but that's good to know. And I'll definitely contact them and make some connections.
I think that, the Kosten Foundation in its own right, has done important work and should exist as it is. And I think that Nikki Mitchell should exist as it is, but because, that there's a lot of grassroots work locally for these different things, but also you know, I'm sure there's certain things that were in which efforts could be combined, because I said the culture and the personality of the group reminds me very much of this group, and they're warm-hearted people who are dedicated. You know, I can always make the connection if you want to.
Okay, good. I'll probably take you up on that, but
Okay.
But as
sounds
Alan
good.
said, you know, there are other probably larger pancreatic cancer research foundations than us, like the Lusk Garden or Pancreatic Cancer Action Network or Wings of Hope in Colorado.
And,
But we haven't really heard of any, you know, patient support groups that meet regularly and interface like we do at any of these larger groups.
yeah, well, so here's,
I
go
can
ahead.
sort of confirm that because that's why I'm calling in from Northern Michigan to a Memphis
Yeah.
support group.
There you go.
So let me just say a few words about that. You know, we work with PanCan and we work with Lusk Garden, and they're both wonderful. And then, you know, PanCan in itself is a huge group, but it
Sure.
doesn't fulfill this niche, and it's
Yeah.
not as personalized. And if I look at,
That's
you know, every group needs to have its role, and I think that what PanCan does really well is that they advocate for policy changes and for influence, and I think that they do a great job of that.
Yeah.
They don't do this personalized one-on-one care. They're not aggressive about funding out of the box type research, and that's okay. It's not part of their mission. So although these groups may be larger, you know, that everything fills a niche, and it's not like because they're larger, they're more important or have a larger impact. I mean, that your impact is just as large as any of those larger organizations. Lusk Garden is very, very much focused on furthering the science, and that's great. But again, they don't have a lot of patient resources. And,
Right.
you know, one of the things is that, yes, of course, we look to the future, you know, to improve things in the future. But the fact of the matter is there's patients in the here and now who have to use the tools that we have and navigate the system. And organizations like this and the Nikki Mitchell, you know, are, like I said, I have a pretty good handle of the national picture, are two
Yeah.
that are near and dear to my heart in terms of the grassroots work that's done, and actually just the you know, the connection and dedication of the group with the patients. So.
Yeah. Tommy, I know there's probably another group knocking on your door to get in and set up. You want
Heard,
to
yeah,
close us out?
let me check and see.
While we're doing that, you know, I have made contacts with PanCam, and they have actually helped me to identify clinical research studies across the nation, which I actually have also contacted a group called Sarah Connor Research Institute in Nashville that I'm looking at as well. Just wanted to bring that out there. I know there's a couple of points made about Nashville and PanCam that I wanted to act my thoughts or experience.
Philip.
No Charmets yet. That's the name of the
Philip.
group. Oh.
Oh, yeah. Philip, Jackie Walls, who could not be on the call, was also kind of looking for some clinical trial information. Would it be okay if I connected you all and shared contact information?
Yeah, we've had side conversations already, so
Okay.
that's happy to do that. And, you know, feel free, anyone, you know, feel free to reach out anytime because, again, helps keep my brain working. I know others can relate to that. So
yeah,
my intent's not to be annoying. I'm kind of procurement oriented, so I'm rather direct sometimes. So I apologize for my personality.
So I'm sure most of the group knows here, but you can go to nih.gov clinical trials, and every clinical trial in the United States, for whatever cancer is there. It is overwhelming. I always suggest that people sit with their, I mean, I do it even with the surgical patients, but also sit maybe with their oncologist to help sort through that. But the entire denominator of all trials is out there in one spot. It's just overwhelming, even as a clinician, for me to use, but it's out there.
Okay. I also wanted to thank Jeffrey Goldberg and Dr. Stephen Bierman for being here. They're on the board of the Kosten Foundation, of course, along with Alan and Tommy, and we just really appreciate y'all joining us this morning and seeing our group members and hearing this great presentation.
Mm-hmm.
Pleasure.
Thank you.
Thank you.
Thank you.
You.
Thank you for the opportunity. It's great.
All right.
Very nice.
I-
Nice job.
Thanks, Chris.
Look forward to it in the future, and I look forward to the continued relationship.
Thank you.
Thank
Absolutely.
you.
Thank you, Chris.
Take care.
Thank you.
Bye-bye.
Thanks,
I'll
Tommy.
leave if you need to speak in private. So I'm not being disinterested, but I just think maybe you want to speak in private, and I'll leave.
No, we appreciate your time.
Thank
Okay.
you.
Definitely.
I'll leave you online.
That's
Tommy,
Shannon.
anything else that we need to go over? I mean, we got October 26th on our
Yeah, we want to
calendar.
put
We
the
got
things in here.
September 13th on our calendar for our next meeting. I'm gonna send out a
haven't-
follow-up email with hopefully this presentation and information on how to get money to you for the sponsorship.
There you go. I haven't checked about Tribute to Twilight yet, but I'm sure it'll be okay. It'll be sometime.
End of October.
In November, yeah,
Right.
okay.
I thought we can
Okay.
go up to the group. and see if
Anybody
there's
have
no
anything else for the good of the
overcost
cause?
going on.
Thank you so
Shannon's
much
here,
for being here.
Teresa.
Lance is here too.
Hey,
Oh, good.
Shannon and Lance, we appreciate you.
Uh-huh.
Loved watching that beautiful service at the cathedral. That was
Yes,
great.
it was. It
Thank
was.
you so much for live streaming it.
Hey, I
Bye,
just want to
folks.
say one thing if I can. Can you all hear me?
Yeah.
Sure.
Yeah.
Jeffrey, really great meeting. Just to let y'all know, we are going to have a team captain's reception, probably on or about September 16th or so. We should have details wrapped up pretty soon. And as Teresa said, we've launched the site for the Kick It 5K. If you go to kickit5k.raceroster.com, you can see it. And if you need any other information about it, feel free and contact Alan or me.
Jeffrey, will that be at Owen Brennan's again?
We're not sure. We're going to discuss it at our next planning meeting. We have a couple
Okay.
of options, but I
Okay.
think the date is likely. You might want to pencil that date. The
September
16th.
16th?
Yeah, and we'll confirm it.
Okay.
We'll confirm a
Well,
time and a location, probably within a
great.
week.
We have our next meeting on the 13th, so we'll be able to give them the details
Okay.
then, if not before.
Great.
Okay. Okay, folks. I hope you all have a great rest of the weekend. It was always a pleasure to see everybody. Jean and Pam, thank you so much for coming. Patrick, back there, thank you for helping us.
Good to see everybody.
Bye-bye.
Bye.
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 Bye-bye.
Bye.
I did. I didn't bring it up. Dr. Wolfgang gave a seminar back in first too. And he said,
Bye, Alan. Have a good weekend.
Okay, guys.